In this lecture, we're going to have a look at the classification and histopathology of pulp disease. This will, to some extent, build upon the lectures in earlier years, where we looked a little bit at pulp disease in the context of dental caries, which of course is very relevant to the vast majority of abnormalities of the dental pulp. The aims and objectives of the lecture are, you can see on the slide. I'll leave them to read them for yourself, and they outline the things that we expect you to have a look at and know and understand. Now, as far as the dental pulp is concerned, I think it's important just to step back a little bit and have a look at the dental pulp and where it's come from and what its constituents are before we have a look at what might go wrong with it. As you're hopefully aware, the dental pulp develops from dental mesenchyme as part of the overall development of the tooth and its dental hard tissue components. The dental papilla is enclosed by the developing tooth, and it eventually becomes the dental pulp, outlined by a layer of odontoblasts on the dentine surface. It is largely a light fibrovascular connective tissue. During tooth development, as you can see here, these things you might remember in terms of this, the enamel organ, the external enamel epithelium and the internal enamel epithelium. We're probably just about to get formation of hard tissue here, and this is the dental papilla, which is the primitive dental pulp. And as the tooth continues to develop, and as the pulp chamber is completely outlined, the root canal system will be outlined by Hartwig's root sheath. So here we have a reminder of normal pulp anatomy. If you move from the right-hand side, you'll see dentine, and then there is a layer, a thin layer, which has got no cells in it at all. That is the pre-dentine layer. It is dentine matrix, which has been laid down but has not yet become calcified. Next to that, you can see all the nuclei of the odontoblast bodies. And then further then, going out into the connective tissue of the pulp, you can see that there's a relatively cell-free zone. And then beyond that, we come to a cell-rich zone, which is a lot of the nerve plexuses, very superficial, and individual nerves will go from that through the odontoblast layer and into the dentinal tubules. But the bulk of the tissue of the pulp itself is a light fibrovascular connective tissue, lots of fibroblasts, blood vessels, and nerves. You will find that the pulp often contains numbers of inflammatory cells, even in relative health. There are lymphatics there as well. And one of the very interesting things about the dental pulp, which is probably something that's going to become even more important during your practicing lifetime, is that we know that there are undifferentiated stem cells within the pulp. Well, that comes from the fact it is a dental ectomesenchyme, that neurocrest, special developed mesenchyme, I'm not sure. But these cells have been shown to be able to be provoked to differentiate into a whole number of different lineages, and are of great interest to people who are doing research into regenerative medicine. Once the tooth erupts, the pulp still continues as a live tissue, if you like, in conjunction with the dentine. So on an ongoing basis, the odontoblasts are still laying down dentine. So it's now secondary dentine because it's laid down after eruption. That secondary dentine slowly formed, is pretty regular, pretty well formed, and it just means that with age, the pulp gets smaller. However, sometimes you get a stimulus that pushes the formation of dentine on a bit quicker. And we tend to refer to that as tertiary dentine. And it can be reactionary dentine. Now, for example, if you have a carious lesion which is extending into dentine, the pulp dentine complex will respond to that and will lay down dentine at an increased rate in hopefully to shrink the pulp away from the advancing carious lesion. And depending how quickly that's laid down, it dictates how good dentine that is. If it's been laid down reasonably slowly, it tends to be tubular and regular. If it's being laid down quickly, it tends not to be. Another form of tertiary dentine, which you will see less often, is reparative dentine, and that is dentine which is being laid down to repair a defect, for example, a resorption defect, and very often it has a very poor structure, and in some cases might even resemble bone. Pulp stones, unfortunately, are common, and you will find out to your cost at times in doing endodontics just how much of a pain pulp stones can be. Now, they can actually be composed of dentine, which means they're true pulp stones, or just be amorphous calcifications, which are not really pulp stones. And they will increase in number and size with age. So what happens now when things start to go wrong in the pulp? What things can go wrong in the pulp? Well, the vast majority of pulp pathology is inflammatory, and it is pulpitis. It is the most significant disease process in the pulp. But there are other things that go on. Some of them, we call them degenerative. Maybe, in fact, they are actually just age-related changes. Certainly fibrosis and calcifications are to a certain extent. Internal resorption is not, and we're going to talk a little bit more in detail about that towards the end of the session. So what about pulpitis? Well, pulpitis is the single most important disease to affect the pulp. It is inflammation of the pulp, and its most common etiology is related to an advancing dental caries lesion, which provokes an inflammatory response to the bacteria and some of the mediators that are released in response to the infection. Initially, the dentine will respond to that by trying to protect itself, and so the dentine tubules will close over, that's dentine sclerosis, and you'll get reactionary, that's that tertiary dentine that's laid down in response to a stimulus. But pulpitis, you know, hopefully not by experience, is an incredibly painful thing. Now, in coming to university, I don't think I can let you away without actually giving you some education as well, and that education includes not only dentistry, but a little bit of Robert Burns. And he wrote a poem which was called The Address to the Toothache, and you can understand from how he writes just how painful this feels just from the intensity of the words. My curse upon your venom stang that shoots my tortured gums along, and through my luggies many a twang with gnawing vengeance, tearing my nerves with bitter pang like racking engines. Now, I've no idea what the captioning is going to come up with for that, but I'll leave that to sort itself out. So what if we classify pulpitis? Well, classically, inflammation is classed as either acute or chronic. And there are ways of looking at that. It can be acute or chronic from a clinical point of view, or acute and chronic from a pathological point of view. And these, as we will see in a little while, don't often match up very well. But in subdividing it further, we subdivide both acute and chronic into open and closed forms. And open essentially means is that the pulp is open to the oral environment and closed is not. So for example, in open acute pulpitis, pulp is exposed, and that's a tooth fracture. So if you get a blow to your incisor, it snaps the crown, the pulp is immediately exposed. That is an open acute pulpitis. What about acute closed pulpitis? Well, sometimes when the tooth gets traumatized, you will get pulpitis, but the pulp itself is not exposed to the oral environment. So an acute closed pulpitis is relatively rare. Chronic pulpitis, on the other hand, is relatively more common. Chronic open pulpitis tends to be the result of a massive carious lesion, which essentially destroys the crown of the tooth, but for various reasons that we'll see in a little while, pulp vitality is maintained, so you get exposure of the pulp, but a chronically inflamed pulp because of this massive dentine caries cavity. And then closed chronic pulpitis, which is perhaps the most common of them all, due to the effects of dental caries. So what about the etiology? Well, as you can expect, the vast majority of these is bacterial. And in a bacterial infection, it's the plaque bacteria. You know, we have all the different varieties of bacteria you get in dentine caries. They'll extend to the pulp and they will elicit inflammation. Now, dental caries is not the only way that you can get bacteria into a tooth. You can get that via a crack or a fracture. You can get it through a lateral root canal. So for example, if a patient has extensive periodontal disease, that means that a lateral root canal is open to the oral cavity. The bacteria may get in there. Some molar teeth have quite prominent canals in their furcation. And so again, if you have periodontal disease and the bacteria have access to these, they can get access to the pulp that way. And there's a particular rather unusual developmental abnormality of teeth called an invaginated odontome, where during development the crown essentially enfolds on itself And it means it's got this pouch within the crown of the tooth. And again, bacteria find it easy to get into the pulp through that developmental abnormality in the tooth. Now, there's always been a suggestion of, can you get pulpitis? Can you get bacteria into the pulp by bacteremia? Now, that is bacteria circulating that then lodge in the tissue. Theoretically, it's possible. In practice, I'm not sure that it's ever been proven. Anyway, here are a few examples. Not got any human examples to show you, but this is a classic example, in fact, of an acute open pulpitis. Bull elephants fight, and they will break their tusks. And this, you can see here, you can, on the picture on the left, you can just about see the remains of the tusk. And then that's the pulp of the tooth, essentially, in the center of the tusk. You can imagine that's going to be exquisitely painful. And these are difficult things that then need to be treated. And I have a friend and colleague who is a veterinary maxillofacial surgeon, and one of the things that he does is that he does the extractions for these. Sometimes he tries endodontics, and I'm going to show you a little bit of that later on, but mostly he does the extraction of these fractured tusks. And I've actually put one of the videos up of him extracting a tusk in with the lecture slides, so you can look at that if you wish, if it's something that interests you. What about other causes of pulpitis? Well, there are some. So you can have physical trauma to the pulp, and that can be by a direct blow, as we've indicated. But the rest of the list that's on this slide here are things that you can do as a dentist to the pulp. Excessive heat. If you use an air rotor that's not cooled, well then essentially you will cook the pulp and you'll elicit inflammation. If you excessively dry it, that is desiccation, that's over enthusiastic use of your 3-in-1, again you can dry out the pulp and you will elicit inflammation. The materials that we use in teeth are also very important. So filling materials, cavity liners and so on can also be irritant to the pulp and cause pulpitis. And to some extent, you want that. For example, some of the way in which calcium hydroxide works is just by provoking the pulp to try and make a calcific barrier to shrink back a bit. So it's not all bad news, but again, you can get pulpitis in that context. And then, of course, mechanically, if you actually just drop physically into the pulp, I suppose that really essentially is a direct blow. So in cavity prep, you can, again, cause pulpitis. Others secondary to the non-carious tooth loss, attrition, abrasion, erosion, they are all going to reduce the amount of tooth substance which protects the pulp, and you can get pulpitis as a result of that. So what about the clinical features? Well, classically, pulpitis pain is poorly localized. So in many cases, you will find that the patient will not be able to identify the particular tooth that is affected, and that is due to the differences in the nerves which are innervating the pulp and those which are innervating the surrounding tissues. The pain may radiate, so it may radiate to the jaw, to the neck, and to the face, and it can be continuous or intermittent. But in many ways, the most important thing that you're actually wanting to know about pulp is this pulpitis something which has a possibility of resolving or not? That is it reversible or is it irreversible? If it's reversible, then you may be able to remove whatever cause it is and the pulp will recover. If it is irreversible, and it can be either symptomatic, the patient will be in extensive pain, or asymptomatic, well then you are essentially dealing with a situation where you're moving towards endodontics. I'm not going to say really very much more about that, and that how you work out the idea whether you have reversible or irreversible pulpitis, the restorative guys, Mr. Barber in particular, will cover with you in a lot more detail. The one thing which I will say in relation to the histology is that there really is little or no correlation between the clinical features, that is whether you've got irreversible or reversible pulpitis, whether it's symptomatic or not, and the extent of pulp inflammation seen when we look at it histologically. You can have a tooth which has got very little inflammation and has been very hot, symptomatic, and vice versa. So in the next section of this lecture, we're going to have a look at the natural history of pulpitis. How does it progress and what are the consequences of it? And we'll come to that in the next video.